Gives me great pleasure to introduce Dr. Anthony Lieu, who's a dual-trained infectious diseases physician and medical microbiologist at Vancouver Coastal Health and clinical assistant professor at the University of British Columbia. He completed his residency in infectious diseases and medical microbiology at the University of Calgary in McGill, followed by a clinical fellowship for transplant ID at Stanford University. Academic interests focus on fungal diagnostics and immune-compromised hosts. It has authored over 25 peer-reviewed publications already. Welcome, Anthony, and thanks so much for joining us today. We can start. As per my understanding, there's going to be some polling, so have your devices ready. If you could provide a summary at the very end of your clinical, like the clinical case history, that'll be great because we're going to keep getting people coming in and joining us. Thank you. Floor is
Absolutely. Um, Thanks, Howard,
The
for the introduction.
transplant infectious disease.
Oh, Kyle, I think you're on mute. Okay, excellent. So in terms of the question poll, there's a QR code at the bottom right when we'll get to the questions. And thank you for the introduction here. I'll start with the land acknowledgement. Gathered today here in Vancouver in the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh people, and quite lucky to be privileged to work and plan this land. No conflict of interest to disclose. We'll jump right in our case presentation here. So this is a 54-year-old gentleman who had a complex cardiac history presented to his local hospital in spring of this year with a history of pruritus and elevated cholecystated liver enzymes. In terms of his history, he's known for a congenital heart disease, cyanotic heart disease with tricuspid atresia, for which at a young age he underwent a classic Fontaine procedure, as you can see on the top right. He actually had 3 transplants, one in summer of 2023 for his heart. This was complicated with ATN and he required dialysis following his transplant. In fall 2023, he got a liver transplantation for congested liver. And finally, more recently in kidney, he had a mismatched transplant for a kidney, which this was complicated with ESBL E. coli and E. fecalis, perinephritic collections. On admission, when he presented to his local hospital, he was on tacrolimus, MMF 500 BID due to cytopenias, and prednisone 5 daily. A little bit of background about our patient right here. He's born in Canada and he lives in rural interior BC in Trailer Park. This is a picture of where he lives. He lives with his mother and is on disability. He used to work as a welder up until his up until his liver transplantation. He has no recent international travels, no pets, and has one adult child for which the adult child lives with his mother. And in terms of his habits, he consumes alcohol in the past, but nothing in terms of recreational drug use or tobacco use. From an antimicrobial perspective, on admission, he was on prophylaxis dapsone and had completed a course of valganciclovir following for primary infection following prophylaxis with letermovir. On his prior infectious disease, he had primary CMV infection about 3 weeks prior to presentation with adequate response. So when he presented on the assessment role for our colleagues back in interior BC, he came in a context of fever, sore throat, cough, and diarrhea. This was presumed to be viral. He got swabbed, blood cultures, which were all negative, and he was sent home. His CMV was later found to be 1800, and they initiated him on valganciclovir as a possible CMV syndrome without the consultation on transplant infectious disease. However, his symptoms resolved quite rapidly. On clinical assessment on presentation, he appeared well. He was afebrile. He had no tenderness on the abdomen, and his cough had completely resolved, the cough that was there about 2 weeks ago. And when you look at his laboratories, he had mild bicytopenia, leukopenia with neutropenia. His ANCs was around 3.5, but overall quite unremarkable. His eGFR was at baseline, around 25, and his cholestatic liver enzyme was grossly abnormal, mainly cholestatic, with ALP, bilirubin, and GGT being all elevated, while AST/ALT was within normal range. And his CMV responded adequately. He underwent CT and MRI, which showed moderate to severe intra and extra hepatic biliary duct dilatation with an abrupt transition point without any obstruction seen. And for this reason, he was sent to our tertiary care hospital at Vancouver for an ERCP. But they did blood cultures routinely, and this yielded at 3 days 2 out of 4 bottles flagged positive, both on aerobic only, peripheral. He had no central line, and this grew on chocolate and BA. On the left, this is the gram stain at 40x, and on the right, this is on the chocolate growth. So we'll go through the first question here. I'll ask you to take a QR code on the bottom right here to answer the first question. What is the organism seen on the gram stain here? Are we having budding yeast, gram-positive cocci cluster, gram-negative cocci under decolorized, mold, or what does Maldi say? So I'll give it one more minute.
Do we have any microscopy? Oh, that's the microscopy.
Yeah, bottom right is so the top left is the gram stain. The top right is the chocolate. We'll have more pictures afterwards. Excellent. So in terms of results, what I have here is the majority said yeast at 50%, 13% said gram-positive cocci cluster, 25 gram-negative cocci under decolorized, and a 13% for what does Malditov says. So what we had here is this was a young growth that was initially called yeast by the laboratory, but as it aged, it became quite demititious. And Malditov on the strain itself showed that this confirmed the presence of Exophyla dermatitidis. On the bottom right, we had a young colony done on lactophenol blue showcasing this organism. And although he was initially on micafungin locally, he was switched rapidly on voriconazole. His repeat blood cultures was only collected at day 4 and day 8 because of the delay in terms of growth, and day 10, day 12 was negative. So at this point, he's transferred to VGH, and we first see him. So at Vancouver General Hospital, on general appearance, he looked well, afebrile, not toxic. And luckily, we had a heart transplant fellow rotating with the transplant team at this week. And on assessment, clearly there was some abnormalities. For one, he had a pulsatile mass that was apparent on his chest wall. But two, he had a systolic murmur with a large V wave sign, suggestive of a severe TR. The rest of the exam only showcased onycholysis of his left toenail. Further investigation showed that the clipping was negative. He underwent CT scan of his chest. As you can see here on the top right, what we do see here is a new pseudoaneurysm arising for his native aorta and at the site of his anastomosis from his first surgery itself. And the last two bottom right pictures are 3D reconstruction of this pseudoaneurysm that is actually pulsating through his chest wall. There was also a thrombus adherent to his aneurysm neck. So we get cardiac surgery to see the patient. And here are the arrow signs. So cardiac surgery urgently brought our patient to the operating room. And they had to redo the sterometer, repair his ascending aorta, and resected the pseudoaneurysm. Very interestingly, when they went in, they found something they have never seen before. They had a black fungus attached to the anastomosis, as you could see here. His intraoperative findings showed that his TR was actually not as severe. And not only there was a black fungus attached to his anastomosis, his aorta was infected with a black plaque for which they removed as much as they could, but they could not fully obtain source control. They did an aortic replacement with a hemishield, and the OR culture grew Exophyla dermatitidis and 2 strains of Staph epidermidis. So in terms of objective today, we'll talk about the microbiological finding and terminology of demititious mold infection. We'll review the risk factor and epidemiology of Exophyla, explore the treatment strategy, and discuss infection prevention strategy in our transplant patient from a safe living practice perspective. So starting with a systematic approach from a microbiologic perspective. In the mycology lab, although we're moving more and more to genotypic sequencing and MALDI, it's also important to understand a little bit more in terms of the morphological differentiation and how we classify them. The first branch I like to start with is this is septated versus aseptated, and clearly here we're in the septated phase. And often in transplant infectious disease, the main organism we think about are either hylohyphomycosis, aspergillus being the main one, dimorphics. We had a few cases of histo, of cocci that was discussed previously, or mucormycosis. The other two class of mold that we don't think as much about are pheohyphomycosis, or what we call the metiches. The pheohyphomycosis is the syndrome caused by these mold, or dermatophyte, which mainly digests keratin and causes skin and hair, skin and nails infection. So our organism is a demeticious, meaning that it has melanin in its cell wall. And these are the main organisms you may encounter. And really, the two ones that we get really concerned about are risk group threes are Cladophila bantiana and Rhinocladiella mackenzie that has a propensity to cause CNS infection. For most, Exophyla is not one that is usually pathogenic. And finally, the last part here in terms of classification that is important to know that is there certain mold that may look dark, like Cytosporum elomentospora, but actually have no melanin in their cell wall. So depending on the literature you may read, they may be classified under pheo or hylo, but in general consensus, Cytosporum elomentospora tends to be more in the hylohyphomycosis. And the one in terms of the demeticious mold is highly confusing because it started with historical histopathological classification. In the past, when we think about pheohyphomycosis, we think about certain CNS disease, we think about certain severe disease associated with it. But actually, it's quite a heterogeneous group of mycotic infections that just contains mold or yeast that contains elements of melanin. More, what you'll see in the literature is what we talk about chromoblastomycosis and eukaryotic mycetoma that are mainly seen in tropical or warmer countries, for which those are mainly through histopathological diagnosis, where for chromoblastomycosis, we hear the term sclerotic bodies, medlar bodies, or copper pennies. For mature folk, we talk about chronic granulomatosis infection, the skin and soft tissue infection, but these could also be caused by bacteria or other pathogen that might not be mold. So a different way of seeing it is on the left side here is a Venn diagram where pheohyphomycosis is more of that overarching term that encompasses those demeticious infection. And to be clear, a lot of those, when you see them from the merger of time, we think about them as environmental or possibly contaminated of the laboratory. So as a transplant infectious disease, when we do see them, we really have to take time to think, is this really an infection or could that be environmental contaminant? And in terms of this Venn diagram, to differentiate these are the overlapping infection you may see. Superficial infections are subcutaneous, chromoblastomycosis, and mycotic mycetoma that, as you can see here, has both mold and organisms that are not necessarily demeticious mold. And finally, one of the concerning ones is when they have invasive disease involving either CNS, endocarditis, sinusitis, and disseminated disease. So from a lab diagnostic, what you could see is from a direct histopathology perspective, you could see melanization of the fungi cell wall, as you can see on the top right here. And one stain that could help you differentiate these is the Fontana masson, but usually as the melanin is quite obvious, your general H&E will be able to detect those. On culture, they grow quite well on standard fungal cultures, but if you use chocolate or blood, they may grow, but quite slowly. And blood culture is quite unusual to see these pathogens from a blood culture bottle perspective. And similar to other molds, you could use potato dextro agar or water agar to stimulate sexual structure. And what you'll see on colonies there, they tend to be dark with melanin, and some of them, including Exophyla, starts like a yeast. From a microscopic morphology perspective, in the past, that was mainly what we used to get to genus and species level. But nowadays, with better database with MALDI-TOF and with the Lieu and MALDI-TOF in most laboratories, these are often used as first line now to identify certain of the harder mold. And also certain laboratory will have access to on-site sequencing. So the second question here I have for you is, where could he have acquired the infection here? So I'm just going to activate the second question. Excellent. So on the bottom right, or you could use the link at the bottom left, where could he have acquired the infection? So one, translocation from his own GI flora. Two, healthcare associated source. Three, black mold from a prior flooding at his household. Four, contaminated water source. Or five, soil and decaying plant matter. So I'll give it a minute. Alrighty. So in terms of answers, the majority answers soil and decaying matter at 55%, followed by healthcare associated or black mold from prior flooding at 18%, and 9% from contaminated water source. As in transplant infectious disease, there's rarely one answer, and sometimes there's potentially a bad answer. So we try to investigate where this could have come from. So first, let's talk about the organism itself. This is a pathogen that is mainly seen, a fungi that is mainly seen in organic matter, including soil, wood, plant, water. The colonies itself, they look like yeast at first, and after 3 to 4 weeks, they develop this olive gray aerial hyphae. So in fact, for most of the bronchoscopy you'll get or skin and nail findings, when we see it, we don't mistake it for a yeast because we tend to read these plates about once or twice a week maximum. So usually they're starting to develop into a mold, and we don't necessarily think of them as a yeast. However, this was a blood culture, which was a little bit unusual. In terms of the spectrum of disease, these infections are mainly seen in skin and nails if infectious. You could also see mycetoma. They could colonize our CF patient, but they can also disseminate, as in this case, causing fungemia and CNS infection. However, most dissemination are seen in elderly immunocompromised, but in fungemia, they're almost universally associated with a catheter. There is not much in terms of guidance given the limited data on this organism, but ECCMID and ACCM were able to provide certain guidance with limited data to support their claims, mainly from expert opinion on their pheohyphomycosis disease caused by blood fungi. So in terms of what do we know about this organism? From an invasive disease perspective, it has a high mortality. These are mainly from case report and case series going through about 30 to 40%. We talked about fungemia being mainly associated with Sinch's venous system, and the treatment itself, although we don't have clear clinical effectiveness data or clinical trials, we do know that because of the propensity of causing bowel film, surgical management when invasive is present is usually recommended in combination of antifungal therapy. For antifungal, there's no clear best antifungal, but in general, their MIC tends to be lower at triazoles and tends to be higher with echinocandin. So in general, triazoles was preferred. ECCMID ACCM, based on expert opinion, recommends using itraconazole, but numerous of the case series would use Vori or another triazoles. And this is with or without terbinafine. So in terms of source, we looked into the data in terms of where you could potentially find this. And of course, it's quite given the aside for central line infection, the data is quite scarce. Could that be from the own flora of the patient? Looking from this data from our European colleagues, they looked in terms of a very high number of feces and put it on fungal cultures to see if any of those would grow exophyla. And there was only a small amount that grew it. And of those, 8 had symptoms of diarrhea, very low colony, making it quite unlikely. How about contaminated water source? These again are often limited to studies published in water journals or public health journals rather than infectious disease journals. So it's hard to bring this to correlation. But there's been contamination of water source distribution system with isophyla seen on shower heads. You can see these as black mold growing on your water appliances. But interestingly, there's an error here for New York. There was a recent in 2017. There was a recent outbreak of exophthalmos dermatitis bloodstream infection in an outpatient oncology clinic, where 17 patients had positive cultures. They all had central line, however, but this was in a short period of time, about 6 months. These patients were mainly treated with voriconazole and catheter removal, and the infection was finally linked to a compound parenteral medication, either the IV flush solution, Vanco, ceftazidime, or heparin, that was stored in a fridge for many weeks. They couldn't comment on this paper. They thought it was mainly the fridge or the solution itself, but this was the link between all these patients. 3 patients died, bringing our mortality to about 18%, but it wasn't clear if it was due to their underlying cancer or due to the infection. Based on the timing itself, it looks like it could be more from their cancer itself. And interestingly, only 1 patient had fever. Most of them were asymptomatic. So we went back to a case and we dug terms in terms of where he could have acquired this. So he denied having any black mold in his household, including his shower heads. He had no catheter, no prosthetic joint material. We discussed about if it was any construction, and given he was quite incapacitated by his 3 transplant, it was mostly in his house and not doing a lot of activities outside his house. But when you go back to his socioeconomic status, we notice that this patient lives in a trailer park. And when we chat about the drinking water, he confirms that this was taken from a well, which sometimes he would remove the cap to take a look at it. And they noticed that in the recent times, it was occasionally covered with a surface film. And this water wasn't tested for a while as well. And if you remember, when he presented, his main symptoms was not related to sepsis, infection, or cardiogenic shock or whatsoever. This was mainly related to biliary obstruction. So he hypothesized that that could have been potentially from his water source. So shifting gears here, we'll talk about. I'd like to hear your end on your part as part of your transplant counseling. Do you discuss about safe water consumption or not when you see your patient, or do you have a pamphlet discussing about these safe water consumption with your patient? So I'm activating the poll everywhere here. You could answer the response on the bottom right, or you could enter it in the chat box. I'll give it 1 more minute. Alrighty. So the majority of our responders replied rarely with 45%, followed by sometimes at 27%. 18% responded often, no one responded always, and 9% responded never. The reason I wanted to bring this up is I've trained in 4 different sites and done some pre-transplant clinic. And although we talk about prevention of respiratory infection, of skin infection, animal, travel, gardening, swimming, and recreational, water is not one that we always think about, especially coming from Canada. And this is a point where I want to chat about here. So the first thing I did with this case here, we also looked in terms of in Vancouver, what are our local safe living strategies in terms of pamphlet that we give to our patients? And the only line we have is untreated drinking infection should be avoided. What does our guidelines and our guidance documents say? Well, they have about 8 pillars of safe living practice that strategies that we talk about patients, for which I think most of us will do for contact and respiratory infection, animal inspection, food, travel, sexual health, recreational. But in Canada, coming from developed countries, water is not one that we often think about. And when we look at a little bit deeper in those recommendations from our colleagues from AST, these recommendations are mainly pertaining to cryptosporidium and other infection related with GI illness, such as they're describing Giardia, for example, if you're going to water, or Legionella for hot tubs. Their recommendation is close attention should be paid in terms of the directive, if there's any advisory from a Health Canada perspective or your provincial perspective in terms of boil water. Well water in area they're not screened should be avoided if possible, and if used, they should be tested yearly for microbial contamination. And avoiding water directly from lake, again, those are the main thing coming from these recommendation. When we look at a pediatric population as well, they do have a one-liner in terms of testing well water. So and finally, when we look at the CST, although we have a recommendation in terms of optimization of our immunization, we don't have any mention about safe living strategy itself. Bring us to this to Canada. The reason I want to talk about this case is to bring some awareness about what's going on in Canada. I think although we are in um, a developed countries, there's still two-thirds of our patient who lives in rural Canada that uses well water. This is heterogeneous across Canada, as you can see on the right side here. And on top of that, about 4 million people in Canada will rely on a private well for their drinking water itself. And when we chat about patients, when we think about well water issues, in the past, when I think about well water, I would think the patient itself will drop a bucket and get some water itself. But most of the well water are connected through a pump and goes through your tap water system at home. It's just that instead of coming from the tap from the city, they're coming from a private or city well itself. So these are the recommendations from Health Canada in terms of what we could do to try to mitigate these infections. Again, these are mainly for bacteria itself. So what they recommend is making sure the cap itself is well secured and tight, having at least annual tests for coliform bacteria, even if the water looks fine, and having periodic tests for inorganic and organic chemical contaminants. The use of water, they do also provide certain recommendation in terms of water safety, such as running cold water for a few minutes each morning after a long period of non-use. Following boil advisory. Finally, the best time to sample the water are listed here. So after spring thaw, heavy rain, long dry spell, or when the well has remained dormant. How about the connection about exophyla and groundwater itself? Most of the studies I could find here are mainly from our colleagues in Slovenia. They have essentially tested numerous, as Slovenia has essentially a big significant proportion of people who uses tap water and groundwater, which was about 40-50%. They were able to detect that exophyla from groundwater sampling was present in about 12% and could contaminate a dishwasher in their household compliance. Up to 40% of dishwashers tested in those patients in those households in one study had exophyla dermatitis. So we go back to our case here. The top right is our MIC. The patient was on Vori and cleared his fungemia. Unfortunately, his post-operative course was complicated with an ischemic bowel and perforation with Klebsiella aeruginosa bacteremia, which required colon resection and open abdomen. Although he was stabilized, maintaining well and non-septic, he was transitioned to a medical ward for which, unfortunately, his repeat imaging showed perigraft collection and was also known to have a sternal dehiscence. It was brought back to OR. They cleaned up. It was quite purulent, for which oral culture grew VRE and Kleb orogenies. However, there was still black mold noted, but now not only around his graft, but on his chest wall cavity. And after ongoing numerous rounds of bedside debridement, as his goal was to live independently without dialysis, and given his overall prognosis and continuous progression despite surgical and medical management, after 2 months, he was transferred to his local hospice near his hometown and recently passed away. So to summarize our case here, and to summarize the teaching point, fetal hypomycosis previously was more of a histopath description, but now really we have to think of it as an encompassing term that encompasses a spectrum of disease caused by edematous modes that goes from superficial to disseminated disease. There are certain molds such as exophyla, particularly that although appears as a yeast early on, will then become a mold. It is also found, this organism is also found in soil, plant material, water source, and may infect medical equipment and home plants. Most tertiary care hospital will use MALDI-TOF or fungal sequencing to get to species, although you could get to genus quite easily by doing a microscopic examination. And finally, treatment includes a combination, at least for invasive disease, of surgical source control, antifungal, and all that we know is echinocandin have poor activities. The optimal agent has yet to be clarified, but triazoles looks to be quite a safe options based on prior case report and case studies. For future recommendation, I think it's good that we need to think about enhancing our pre-transplant counseling, that thinking about water safety, even in Canada, particularly in our patient living in a rural setting. We should also think about improving living practice through numerous avenues. That could be, for example, adding a safe living practice with transplantation in our Canadian Society of Transplant documentation, giving local practice brochure to patients, discussing about it at our visit pre-transplant or post-transplant, and finally educating the primary care provider of the patients who may see the patient on a more frequent basis. And it's also important to advocate, support this to the access to safe drinking water. Particularly in Canada, we had a few incidents recently about our Indigenous patient population where they could not get safe drinking water per se. So I'd like to thank you for your attention. I think we're at 40 minutes, and I'll go respond to some questions. I see that Dr. Kabani is asking, we're assuming that is the water or it is the water or his water was tested. No, at the moment it's mainly assumption. His water was clean after a discussion, but we didn't have sampling of the water. And like in a lot of things in transplant infectious disease, we may not find the silver bullet of the clear cause of what is the causative or where he got the infection per se. But this is an assumption based on GI translocation, based on his biliary obstruction, and based on looking for traditional source of this infection.
So until really, really interesting. Anthony, thanks so much. Until we get more questions, I have a couple. So do you think the ischemic bowel, so the Klebsiella is likely a secondary issue to the ischemic bowel and the perf that happened. Do you think that was linked to the exophiella? Like, was it a disseminated infection in your opinion?
So they did, that's a good question, Sarah. We did send some 2 OR symptoms from the gut for fungal cultures and histopathology, which did not show any evidence of black mold. And we also talked to the general surgeon, did not see any change that would be unusual for like a mold infection. We think it's a separate process because after the first surgery of the patient, he was quite ischemic, requiring high pressure requirement. And that's the assumption, but it could have been precipitated, possibly. Perhaps the patient was already treated with the voriconazole and we couldn't find evidence of it.
There's Dr. Gunarantam and then Dr. Kabani.
Yeah, there was a fantastic session. I really enjoyed a lot. I'm not an infectious disease person, but learned a lot. Thank you very much, Dr. Lieu. I'm a bit surprised we don't see more of this. Was it the specific combination of the immunosuppression plus maybe a concomitant infection? Why is it that we don't see more of this, especially the indigenous populations we serve as well?
Yeah, it's a great question. I would say twofold. Part of the reason is the immunosuppressant perspective. Although you may be exposed to mold, the majority of GI mold that you're exposed to, if you have an intact immune system, you're not going to have any diseases as well. And we do see that sometimes, for example, GI mucor is excessively rare and only seen in the most immunocompromised patient. So that's one of the reason why you may not see it. And two, in terms of infection, if you were to get an infection from water, parasites or bacteria are much more likely to occur than mold itself. I think this is a patient that had a unique combination of living in a rural area, in a
Mm-hmm.
trailer park, and being triple transplanted. So that
Mm-hmm.
was a unique cocktail why he was probably the only patient in his community that occurred.
Thank you very much.
Dr. Cavani?
Anthony, that was a very nice review. Couple of questions just to think more about this case. So, marijuana use and fungal infection. So, have we gone that route? And then the second thing that make me uh, pause at this patient is the reason for his initial transplant was actually Fontan, right? And some of these patients develop protein losing enteropathy after many years. So did he have this entity, and has anybody checked his immunoglobulin level? Did he have a lymphopenia? And then my third question is, it's interesting where the infection occurred. I mean, it's around his initial transplant, which was the heart, right? And you think that he's had a liver, then a kidney, and why is it around the initial graft? So these are my thoughts and question. Thanks.
Thank you for your thought, Dr. Kamani. Very, very good questions. Was lymphopenic when he came, particularly with his immunosuppression, but not profoundly. He was, I have to double check, but I want to say zero point 0.4 to zero point 0.6 approximately. In terms of your first question about protein losing enteropathy, I'm not aware. I did not look specifically into this. It was not one of the past medical history that was in his chart. When you look at him, he did not look like a patient that was sarcopenic from that perspective. And after his Fontaine, he was actually working as a welder for numerous years up until his first transplant. Maybe that may have been more prevalent before this presentation, but I'm not aware of. I'm not sure if Dr. Sarah could comment if she could remember. She remembers any of this. So that's for your that question. And now regarding your second your question, why the heart and not the other anastomosis from transplant? That's a really good question, which I don't think we'll have a clear answer. Um, what is interesting, however, is when you go through these case series and case report, fungemia has been associated with endovascular infection involving the heart or causing endocarditis as well with exophyla. So perhaps the fungi with this dematicious have a propensity for cardiac muscle tissue or or aortic tissue rather than other type of tissue. We do know that with certain dematicious, they have a neurotropic. Perhaps this one has a bit more of a cardiotropic. Interestingly, prior to his transplant, to his presentation, we had prior scans that did not showcase a aneurysm that appeared. So that looked to be quite fast.
And my last one, did you ask him about any
Oh,
marijuana or
marijuana. Yeah,
substance use or?
yeah, that's a good question. In the past, he did consume marijuana. Since his transplant, he hasn't been consuming per our history when he came to VGH. But it's a good thought for the we do have we do have patients that consume, especially in Vancouver, quite a bit, for which we counsel them on the risk of mold, although the association is not as strong. But the mechanism for this patient, if it was inhalation, we would expect to have a pulmonary finding before going to the bloodstream.
Unless he was taking them, right? So it doesn't have to be, some people ingest these things. So that's why.
That's a good thought. Dr. Trachtenberg?
Hi there. I'm from Winnipeg. I'm one of the kidney transplant doctors here. This is probably a basic question, but in these fungal infections, like this case, what's the yield of the blood cultures? Like when we have these patients that have a fever, NYD, and their blood cultures are negative, how how much effort should we put in pursuing a hidden fungal infection that's disseminated but with negative blood cultures?
No, that's an excellent question. In fact, for most of fungal, and when we talk about fungal, we think about yeast or mold, but I'll focus on the mold itself because most of the yeast candida, for example, will grow pretty easily on blood cultures. For mold, the general rule is they're extremely, extremely difficult to grow. And blood cultures being negative does not exclude any fungal infection, when I talk fungal, mold infection at all. And in fact, most of their diagnoses are either through invasive sampling or going directly to the source of the infection where it's coming from. This was a quite unique one where I think at VGH, I looked at the last 5 year of data, and it was the only exophyla cases we had in central blood infection per se. Now, in regards to your question here, there's a few molds that have classic association with bloodstream infection. I'd say those are particularly seen in your bone marrow transplant patients. For example, Fusarium is the classic one with skin infection and blood infection and bloodstream infection. But in general, from a rule of thumb perspective, if you're suspecting mucor aspergillus, blood cultures will not help you, and you should go directly to where the disease is, either lungs, for example, or sinus, rather than you using your blood. Of course, you're obtaining blood cultures because you have fever, but I would not use it as a rule in or out. The only small caveat here is there's certain infections such as histoplasma, which may grow on blood. However, it takes quite a bit of time, and you need a special type of blood culture bottle called a microaphilitic bottle, or a bottle that has a way to break up the cells and release the intracellular pathogens. However, for histo, for example, we have other diagnostic tests that are better, such as antigen testing.
Okay, excellent. Thank you.
I have a question. First of all, the counseling about the water piece is really interesting. We had a patient who drank from a well, had a stem cell transplant for MDS, and actually we saw him for Aeromonas bacteremia cellulitis, and then we screened for neck fashion. He did eventually have neck fashion, was operated on, and I think that was the only case that we saw that's related to well water consumption. My question though is to the microbiologist piece in you. I know, so Exophiala has been reported to be having reasonable MICs, Devori and Posa. Do you ever bother getting MICs? And I think in this patient, he was probably not going to make it to begin with because of everything, like his background and the nature of his infection. But you know how sometimes we add things like terbinafine for Lamentaspora, hoping for some sort of synergy. And I don't know if Vancouver does any synergy testing. I know in Ontario we cannot get that done. I don't know if Toronto is different, but we typically can't request synergy testing. I was interested in hearing your thoughts on that.
Yeah, no, that's a really good question. It's often one that is being asked when you're on the microbiology perspective in terms of MIC. First of all, I'd say that there's not a lot of breakpoints for mold. There's a few molds that have breakpoints. Those are the ones we're comfortable calling susceptible or not. When we get to MICs, it's partly because we don't have a lot of information. And there's one thing about mold testing, it's highly partially subjective, but the CLSI allow us for two dilution difference. So if you're testing like a mold at 1, that is the reference method, and you're testing it at a dilution of 4 of MIC, this is still considered a essential agreement, meaning that it's still accurate. So that's part of the reason you have to be quite cautious. When I do MIC testing itself, I do it in those cases where they're refractory or you may be on a long-term course of treatment, but with a caveat of the interpretation. If the MIC is very, very high or very, very low, it may be helpful for most, but however, most of the time they're in the middle. And in the middle, it's very hard to draw a conclusion based on the MIC per se. So that's where I would caution you. And if you look at certain data, particularly for the Fusarium MICs, MICs did not predict mortality. What really predicts mortality is if their immune system recovers or the use of corticosteroids. And this is like a general thing with mold itself. The majority of the time, the reason you get mold as well is because you don't have either it's a source control problem or your immune system is incapable of controlling it. So your medication, whichever you're using itself, although it may help to control it a little bit, it's not your panacea in the end. And now for the synergy testing, those are it's very include in vitro data to in vivo without clinical data, I'd caution the terbinafine interpretation for that reason. I know in our peers in the States, for those very resistant to Xarium or Cephalosporin or Lomentospora, they start moving away to those newer agents like fosmanogepix or olorofilm, but it is a challenge in Canada in obtaining them. In refractory cases or resistant, we've done upfront triple with Vori, Ampho, and terbinafine. But I think in those cases, it's worth looking into it. However, interpretation, a lot of caution. In fact, while I was at Stanford, would refuse most of our mold MIC testing because of how clinicians like to overinterpret a number that is so far from what is the clinical reality.
Yeah, absolutely. And for fosmanogepix, at least, they do require, if you want to get the drug, the company is willing to provide it, but you have to give them a sample that they test in Texas. And so it's a bit difficult. Thank you so much. Do we have any other questions?